Thank you. James Davis.
Thank you, Chair. A couple of questions, if I may, to either or both witnesses, to ask to what extent recruitment and retention issues of staff impact on the quality and safety of maternity services in your experience. Professor Baker first, perhaps.
Oh, no. I'm sorry, that was certainly a feature at Morecambe Bay, and it's been a feature of other investigations that I've been involved with, not necessarily in maternity services. It's one of the products of this thing that I've been loosely calling clinical isolation. There are locations where it is very difficult to recruit staff, and that can become a serious factor in their standards slipping and not being spotted outside, in my experience. But I'm sure that Professor Baker has a view on that too.
Well, I would agree with what Dr. Kirkham said. I think the recruitment and the number of staff is better than it was. Certainly after Morecambe Bay, when Dr. Kirkham identified those problems in Morecambe Bay, we were very, very assertive in insisting units have the right level of staffing, and they have improved, but we still do see elements of that. I think that there's a kind of background to this. That there is a big attrition rate both in trainee obstetrics and midwifery. And if you actually look at the statistics and staff feedback, those specialties have a lot of bullying. And that is part, I think, it is linked to the culture and the safety problems we are talking about. I think that creates tensions in teams that makes it actually very difficult to work. And I suspect we lose a lot of good people from some units, but from the profession entirely, because of the way we look after them in terms of the culture in which we make them work. And managing high-risk obstetrics is very stressful. And people need to be supported, and they need to be accepted, as they are. And it comes back to this issue about, if we say to an obstetrician, you've got to be infallible, then clearly when something goes wrong, they lose a lot of their own self-worth at that stage. And asking them to stay in the profession, I think, is difficult. But if we support them and their fallibility and help them learn and improve over their professional lifetime, I think we can keep them in the profession. So I think it is an issue of numbers of staff, but also it's an issue of how we look after the staff we've got.
That's very helpful, thank you. And Dr. Kirkup, just to expand on an issue that Dr. Luke Evans was raising just now in terms of the structures of services, I'm interested, as an MP representing a relatively rural area, about the ratio of midwifery-led units versus doctor-led obstetric units and the distances between those for access of care. Have you come across situations where women are finding that the distances involved are too great and pose a risk?
That is exactly the issue that we looked at in North Cumbria, which is a relatively spread population with a couple of urban centres and a large rural hinterland in between. It seems to me that where you can provide an obstetric service and a midwife-led service so that women have choice, then you have the best of both worlds. That's what they managed to achieve in North Cumbria. I think one of the key points in making that sustainable in areas like that in the future is how we train junior clinicians. And the more that we tend to centralise their training into the metropolitan areas, the less attractive the rural places seem. We do that because Royal Colleges by and large like training to be in large centres with big rotas of doctors, and don't trained in smaller units. If we were able to be more flexible about that and train people in places like that, I had the great good fortune to be trained in a couple of them, including Hexham, which is quite a small unit. Actually, the experience is fantastic, and it gives you much more likelihood that you will go and practice in a place like that in the future and keep them sustainable.
Excellent. Thank you very much. Thank you, Chair.